Hello, and welcome to Health Talk, a show where we dive into common health challenges with local experts to bring you the information that you need to live your best, healthiest life. My name is Dr. Desmar Walks, family physician and local health authority for Austin-Travis County.
Substance addiction can happen to anybody, but recovery is always possible. There are many ways to help prevent and treat addiction by recognizing the signs and supporting the mental health of yourselves and your loved ones. In today's episode, we want to dive into discussing substance use, addiction, harm recovery, and the latest treatments for effective recovery. Our guests are Dr. John Weems, addiction medicine specialist at Community Cares, and Maggie Luna, executive director of the Texas Harm Reduction Alliance. Dr. John Weems is a practicing internal medicine physician and addiction medicine specialist serving the medically underserved communities in Austin at Community Care Clinics, where he helps run the wellness and holistic addiction medicine clinics. John also trains medical students and helps improve hospital-based addiction care at the University of Texas at Austin Dell Medical School, where he is an assistant professor of internal medicine. Director Maggie Luna serves as CEO and executive director of the Texas Harm Reduction Alliance, an organization working on the ground with people across the spectrum of drug use, offering radical harm reduction services, advocacy, education, and training. She has a background in research, coordinating activities, and communicating issues related to reducing the prison population and changing policies in the criminal justice system of Texas. Welcome to our show, John and Maggie. First, I'd love for each of you to have a chance to introduce yourself and also talk about why you're doing this. What got you into this work?
Okay, so I am Maggie. I'm the executive director at Texas Harm Reduction Alliance, and what led me here was a life of opioid use and drug use. Spent 20 years using and feeling hopeless, like that was the life that I was going to succumb to. And so that's my why, is knowing that there are resources and options out there was not something that I knew in the 20 years that I spent out there. And so what keeps me going every single day is knowing that there are people being saved because of these resources.
Thank you, Maggie. John?
Awesome.
What's your why?
So for me, my journey is really different. I don't have that wisdom of lived experience and recovery. I got to go to medical school, which was lifelong dream. A lot of people loved me over there, and I loved it. Great experience learning from all these other nerds who just worked really hard for people and this noble profession. And there was a group of people who were kind of an exception, kind of like a kryptonite for the kinds of thinking and care that we need for other patients as people who use drugs. And it made me angry. And I think a lot of people's passion starts with those kinds of movements of the soul. So for me, it was noticing this and then learning there's all these things. I also had no idea because we didn't learn about it in med school. It's like that for you, Dr. Walks, but I think in our profession and many, we just never learned about this. And part of the why that keeps me going is being able to be a part of changing medical education so that we do learn the evidence-based tools. But even more important, just like how fun it is to take care of folks who've gotten, are struggling with addiction, to learn what resilience looks like, and to learn from just like the coolest people who've gotten over a really hard problem with fulfilling lives is the why it keeps me.
Thank you for that. What are some of the signs and symptoms that you could tell our audience you might notice if a loved one is using?
I can just speak from personal. Whenever I would isolate. I wouldn't answer my phone. I would not look you in the eye. And I lived with a lot of shame and stigma. So I was trying to hide myself from society because society did not accept anything I was doing.
I think too, from the clinical perspective, one easy definition of a problem with drugs is, loss of control and ongoing use despite consequences. And often for loved ones, what we notice is the consequences. The person I love and depend on isn't showing up in that way. And thanks for Maggie pointing out, so much of it is people are living in their shame and they can't be who they are. And that's not the drugs itself. That's a lot of things that go into that. But some of those signs and symptoms that, might signal there's more going on that loved ones can be concerned about is like if a pattern of use in a cohort of people changes, right? So, people get out of high school, go to college, get out of college, go to the next thing, get from one job to the other, and the way they were using doesn't change along with how their patterns change. It's like, okay, maybe there's something different worth looking into. I think the other thing worth mentioning here is like you don't have to have a substance use problem to suffer an overdose, especially here in Travis County. And we got to get real about that. That, there's my whole world clinically of folks who are struggling, and helping is one thing. And so drug use is very common, especially here. The good news is there's great things that can prevent and respond to overdoses, but you don't have to have a problem to suffer. Does that make sense?
A lot.
So what would you say some of the misconceptions are about substance use or recovery that you're encountering in your day-to-day work?
I think one of the biggest misconceptions that I see is people believe it's a choice. That if they would just pull themselves up, they just get themselves out of it. And I tell people, if I could have woken up one day and not wanted to use drugs, I would have been so happy. But every day I fought that demon. And so a misconception is that I was choosing this every single day. And another one that has been glaring in my entire history of drug use is everybody's on the streets or under the bridge. Or, an alcoholic is just somebody who's living drunk all the time. And that's not true. A lot of the people that I surrounded myself with were doctors and judges and, things that, people you would never, ever assume were using drugs. And that's where I got the best drugs from. So a misconception is that it's just happening to one population, and really it affects everybody. And I came from a really good family I'm the only person out of 9 children who had a drug problem. Mm-hmm. So it could happen to anybody.
That's so true. And I think a misconception that we need to really talk a little bit about is the fact that the medication itself affects the brain, right? And affects that part of your brain that makes you feel good. You want to talk a little bit about that?
Yeah, that's part of what makes us human. We respond to things, to be around people you care about, to love and feel loved. And there's particular mind-altering substances that can, one way this has been talked about is sort of hijacking the brain, and that is one way to look at it. I think sometimes I might miss out on the social aspect of things, but I think maybe I'll step back and say it's a really good point that the drugs talk to a part of our brain that deals with pleasure. Most people who use drugs don't have that response, right? And addiction has its roots in intergenerational trauma and genetic risk. So the vast majority of people who use drugs, even like the so-called heavy drugs, don't develop problems. They experience that pleasure, and then other pleasures are salient, and they move on with their life, their social situation. And some of us get stuck. And that stuckness, again, has to do with genetic risk, trauma, structural violence. And the good news is And I think this gets to one of the misconceptions, right? I think everybody thinks this is a disease unto death, and nothing could be further from the truth. I mean, the natural history of drug problems is resolution, and 9% of Americans are dealing with a resolved drug problem. They're living with it. They're on the other side. They've survived it. They've recovered in their own way. So that's the other big misconception, I think. And again, talking to folks who've gotten over that or are dealing with it it's a really inspiring place to be. And I think that's another thing that has its root in stigma, right? We want to cast people out instead of accepting them as part of who they are.
So talk to me a little bit about what you think are the first steps that can be taken to work towards recovery.
One of the first steps that I had to take was just accepting that there was something there, realizing that my peer could stop and go home for a couple of days, and I was gone for 6 months, and so just accepting the fact that, okay, this is not working for me, and accepting the fact that I was looking for something. And what Dr. Weems just said really hit something, because when I was in my addiction, I always felt like I never knew what happiness was until I was high. And so once I started to work through that trauma and realize that that's not real happiness, now 8 years later, I get really stressed out. And there are really times that, 8 years ago would have sent me. But now I realize there's more to lose. And so just getting to a point where this isn't working for me and I want something different, but nobody could have told me that. My family told me forever, this is not you. And so it wasn't until I just finally accepted I want something better.
And, just piggybacking on that and also thinking about what you just said, John, about shame, how do you think support from friends and family plays into that recovery process?
It reminds me of something you said earlier, which was how much when you were going through it, you wanted somebody you could trust, right? And so what role did family supports play? Somebody you can trust and somebody who you can be safe. It just really struck me. I don't think I have any more. It's so cool.
Well, connection is the opposite of addiction. I'm so isolated when I'm using, but when I know that there's somebody who cares about me, it's different.
Right. And last year, the U.S. Surgeon General issued an advisory about isolation and the lack of connection, and there's more that's coming out now about that, and all of it being linked back to things that were happening before the pandemic, but certainly that it was worse during the pandemic. So having said that, is that what your experience was as well in your places of work, that you were seeing more substance use and during the pandemic and as a result of it?
I think so. I'm curious to hear what it's like at THRA. I mean, on the clinical side, it's unequivocal. I mean, the both mortality related to drug use, alcohol being the leading drug causing increase is clear across the United States, and it started very early, right? And then overdose deaths being 100,000 years. Just unbelievable burden of loss. And it's that isolation, right? It's the isolation, the lack of access to resources, including treatment, and then the desperation of healing. And drug use helps with that. We got to think about it. And it doesn't have to forever, but that's part of how people cope when you're dealing with an unprecedented pandemic of COVID-19, and on top of this longstanding issue of loneliness and isolation. So we see, I think that's a lot of people, things were okay and then they weren't, and COVID had a lot to do.
It's coping with anything. It's
Yeah.
hard.
What strategies can you use to cope when you're trying to recover from the use of addictive substances?
So a lot of it is learned, right?
Mhm.
I didn't realize until I got out of my addiction that there was a lot of things that I didn't even know.
Mhm.
That normal people are brought up in homes that, just know these things. And so today I cope by breathing, by walking away and, putting it into perspective and getting out of that all or nothing thinking, but this is all stuff that has taken me years to learn. And so as I instill that into my child, I can see spaces where he goes into these rages, and those rages would have taken me to go use drugs. And so now I'm able to see that, hey, let's deal with this. Let's figure it out.
Mm-hmm.
And so I think just learning how to handle your emotions early
Mm-hmm.
really wouldn't stop anything, but it is definitely a coping skill for whenever things do hit the fan.
Mm-hmm. And so harm reduction looks different than recovery, right?
Yeah.
Talk about it.
So when I first stopped using, harm reduction was so taboo to me because I believed that you're just replacing one thing for another. And as somebody who lived in an addiction for 20 years, it was hard for me to understand, like, if I don't want to use anymore, and that's not what harm reduction is. That's not what it is. And so I've had to learn that a seatbelt is harm reduction. An Uber is harm reduction when you're coming home from a bar. Vaping is harm reduction. And so when I look at it that way, and it's like, I know where I was at this time in my life, and I did a lot of harm to myself and to my community. And so if we can just jump in and help relieve that harm being done to self and others in any possible way, and it could mean anything. It could be just a shower, somebody could be walking around and not have a phone. That's harm reduction, because I'm gonna scream at so-and-so and try to find something until I get it. And so harm reduction is just reducing that need in any possible way that we can.
So it really isn't just about the place where people find themselves when they're addicted, right? It's upstream. Yeah. We're way off script, guys.
Sorry. Oops.
How do you think harm reduction is different than recovery, John?
I think two thoughts on this. One is, I think from the medical model, and the second one is what everybody can learn from the harm reduction movement. So like harm reduction is a set of interventions. I think this is one way as doctors, like, we got it pretty good. Like, we can understand this, right? We meet people after they've had a heart attack or a stroke, and we do what we call secondary prevention. So Dr. Wag, we prescribe a bunch of meds, recommend some therapies. That's harm reduction.
Mm-hmm.
You're reducing the consequences of a chronic remitting and relapsing disorder. We know how to do that stuff. We also talk to people about sunscreen and about wearing seatbelts, helmets, not driving drunk. We do this stuff.
Mm-hmm.
And so part of me is just like, let's not overthink it. We don't want people to get hurt. Thank God we have these amazing interventions that can do that. For harm reduction as a process, harm reduction as a movement for dignity and human rights by people using drugs, we get to all learn from that. And I think I got the privilege to work with a lot of people in recovery in the clinic I get to work in, and they know I love what it's like. And a lot of them learned it from addictions and from harm reduction, because harm reduction can be a shower. And harm reduction is, hey, I'm so glad you're here. And I hope we're trying to learn that. We're trying to figure that out in our clinic, and a lot of medical settings are, because I think harm reduction is also love.
Mm-hmm.
What's recovery? But I don't want to say any more about that. But like recovery and love, right? They kind of go together pretty good.
Yeah, I think we had a conversation earlier about love, and I think people think about it as the fireworks and, fanfare, but really loving your neighbors, helping them get that food and place to live and a shower and a hand to hold when they need to go get some help. What are some of the key factors that contribute to successful long-term recovery beyond that initial treatment?
Connection has a lot to do with it. When I began to have a community that was holding me accountable, checking on me, and actually, like I said earlier, there were a lot of things I didn't know that I didn't know. And so just the fact that I didn't know how to act in society would push me right back into the life that I knew. And so having somebody who was non-judgmental in saying, hey, that's not how you dress to a job interview,
Mm-hmm.
in a loving way, instead of like, because I already did not like myself. And so if somebody would have told me, like, I've, been judged before, like, that's not, like, normal people don't do that. Okay, well, I know where to be normal, because normal for me is in the streets, So just having a loving community that's, like, showing you the way in a loving way.
Mm-hmm.
That has been the really big hand for me, because it's so crazy how all of these years I see things every day that I never knew in the streets,
Mm-hmm.
and people just know some things.
Mm-hmm.
So just understanding that every life is different and you never know where that person came from.
And every life is valuable.
All of them.
Innovative treatments that are out there for substance use.
I think there's a lot of interest right now in like psychedelics in particular, and other innovative therapies that use things like different technologies. To me, just assessing the evidence, not there yet. There's a lot of excitement, and look, profound experiences change people's lives, whether they have an addiction problem or something or not. So I'm not talking down on any of those, but from a clinical evidence perspective, the good news is we have great treatments that work really, really well. And the new and exciting stuff is you have to get people those treatments for them to work. And the more we do to get them treatments, so like with the COVID-19, relaxing them some of the rules around prescribing buprenorphine, also known as Suboxone, for instance. That is probably one of the most important innovations in addiction medicine in 10 years. Ditto with methadone regulations being regulated. And there's a lot further to go. So I think the innovations are largely around how do we take addiction out of its silo, or the treatment, I should say, out of its silo, and bring it into general medical care, while addressing things like social determinants, to get back to what Maggie was saying, to set the scene for long-term success by giving people recovery capital. One way to think about that is like recovery capital, right? What are the connections, interpersonal skills that people need to build purpose and meaning in the community? If you can marry that with the things we know work, thank goodness there's things that really work, medications, behavioral treatments. There's more and more papers that come out talking about how people have done that, and it's exciting because there's new ways of doing it. But some of it's kind of old hat because the meds work really well.
Mm-hmm. Yeah, I think we talked about harm reduction, talked about recovery, and we've really covered a lot of ground with two amazing guests. And before we close, I want to give you both an opportunity to talk about where the resources are for some of our listeners that may need that information for themselves or for their loved ones. Because there are a lot of people out here who've been working hard collaboratively to be there, to say, hey, we're glad you're here, and to help them along their journey. And so I know we've got some vending machines at the Sunrise Church and at Cenote and at the Sahara Lounge. And I know that we're also available, or you're also available at Texas Harm Reduction Alliance, but can you talk about some of your other harm reduction partners that are out there? And then, John, if you could give us some information about treatment.
Yeah, at Texas Harm Reduction Alliance, we have, we don't provide everything, so we do partner with like host and communities for recovery. We have peers that come visit our participants, and the NICE project is always a good resource. And the Drug Users Health Union, the Never Use Alone hotline, these are people who, it's not about abstinence, it's just about humanity. And so those are really good resources for that.
Thanks, Maggie. John?
Just add a couple naloxone access points. So the peers with community recovery are all stocked with naloxone. And for anybody listening, if you or anybody you know has drugs in their life, particularly pills or powders in Travis County, naloxone is a life-saving medicine that anybody can use and should keep nearby. Other access points, if you have a MAP card, or a MAP basic card, you can access naloxone from a pharmacy, typically HEBs anywhere in Travis County. If you come to one of our clinics, community care clinics, you can get naloxone during your visit free of charge, two units of kit. And then we're talking about the downtown public library is another great place to get naloxone here in Travis County. Other treatment resources. So we're talking earlier about if you or a loved one is struggling, aph.org links to the Travis County HHS site and has its other resources sort of gathered there for where you can access treatment. At our clinics, definitely at our addiction medicine clinic and community care, we'd love to see you down in Montopolis. And we're opening up a new clinic up at Capitol Plaza. And then I would want to give one more shout out to teachoud.org. So if you want to talk to your clinical team, or if you are a clinician listening to this, that is free training and technical assistance coaching to do better in treatment for our patients with neurosis.
And it has continuing medical education credit.
Free. Yeah.
For free, yeah. Thank you both.
That's all the time we have for today's episode of Health Talk. Thank you to KAZI 88.7 and to St. David's Foundation for their support of this program. Until next time, take care of yourselves and each other. This is Dr. Desmore Walks signing off. Be well.